Hello and welcome. This is week number 6 and lecture number 29. Today's lecture is on comparison between meniscal repair versus meniscectomy and what is the evidence behind the rehabilitation protocol for each of these. The objectives for today is to understand meniscal, meniscal anatomy and its role in knee biomechanics. We shall also learn to differentiate between meniscal repair and meniscectomy procedures. We will recognize how surgical choice influences rehabilitation goals and timelines in meniscus injury cases. We will also learn the phase wise evidence based rehab protocols after meniscal repair and meniscectomy. So let's begin with today's lecture. As we all know, meniscus is present between the femur and the tibia. The meniscus is vital for shock absorption, and how we treat it shapes the entire knee's future. A repair means longer protection and a slower rehab, but the payoff is tissue preservation. A meniscectomy allows quicker recovery but comes with long term joint health concerns. Evidence strongly favors saving the meniscus whenever possible, but the rehab has to do justice to the surgical repair. Knowing these differences is essential for planning a safe and effective evidence based rehab protocol. In the 10-year athletic knee injury study published in PubMed, the medial meniscus lesions constitute to about 10.8%, while the lateral meniscus injuries constitute to about 3.7% of all sport related knee injuries. In MRI studies of patients with ACL tear, the prevalence of associated meniscus injury, both the medial meniscus and lateral meniscus, is very high. For example, in one study with a sample size of 254 patients, 57% had medial meniscus injury, while 25% had lateral meniscus injury. In sports such as soccer or football, it is very common to see medial meniscus injury. In sports such as soccer or football, it is very prominent or common to see meniscus injury. But meniscus injury is also common in sports like wrestling, gymnastics, dancing, skiing, and other pivoting and cutting sports. Among children and adolescents, football have high proportions of ACL plus meniscus injuries. The menisci are two crescent-shaped fibrocartilaginous structures. They distribute load, absorb shock, and increase joint congruency. The medial meniscus is less mobile and hence it is more prone to injury, while the lateral meniscus is more mobile and hence it is less prone to injury. The vascular supply of the meniscus is limited, especially in the inner third, which is why healing potential depends on location of the tear. Meniscal tears can be longitudinal, radial, flap, or root tear types. Acute tears often occur in sports with twisting forces like football, volleyball, wrestling, skiing, etc. While degenerative tears are common in older adults, especially in the fifth or sixth decade of life. Symptomatic tears with mechanical locking or persistent pain are usually indications for surgery. Preserving the meniscus whenever possible is critical in improving long term joint health. Let us now discuss the difference between a repair and a meniscectomy. Meniscal repair preserves the native tissue. It restores hoop stresses and delays arthritis. But it requires longer rehab and carries a risk of re-tear. Partial meniscectomy removes damaged tissue and allows faster recovery of an individual. But it also increases joint loading and increases the risk of osteoarthritis. Such patients may have an early total knee replacement surgery. Surgical decision depends on patient age, their activity level, the tear pattern seen, the vascular zone of the injury, the chronicity of the tear, the status of the cartilage, and concomitant injuries if present. Hence, there is no specific kind of surgical intervention for a specific kind of tear. The intervention varies from case to case basis. Multiple studies show that meniscal repair has superior and better long term outcomes when compared to a meniscectomy surgery. Patients undergoing repair have lower rates of osteoarthritis and total knee replacement in the long term, while patients with meniscectomy show a higher incidence of osteoarthritis as well as TKR surgeries. Root repairs, in particular, restore biomechanics close to normal. Although failure rates exist, especially in the avascular zone, the long term benefits strongly favor repair over meniscectomy. Let us now discuss the rehab principles after meniscal repair. The rehab after repair is protective for it to allow biological healing of the meniscus. Weight bearing is limited initially and often undertaken with the help of a brace. In the early stages, only partial weight bearing is encouraged. The knee range of motion is restricted, especially avoiding deep flexion, which stresses the meniscus. No pivoting, twisting, or squatting movement is permitted during the early phases of the rehab. Progression in rehab, as always, is criteria based rather than purely time driven. In the acute phase, the knee is braced in extension, and patients are either non weight bearing or only partially weight bearing, depending on the type of tear and the type of repair done. As the swelling subsides, passive, non weight bearing range of motion is undertaken but restricted to 0 to 90-degree knee flexion. Exercises focus on quadriceps isometrics, straight leg raises, and hip glute activation. This protects the repair from maintaining muscle activity. Key interventions undertaken in this phase are non weight bearing or partial weight bearing, depending on the repair, isometrics, especially for quads, hip, and glutes, heel slides till only 90-degree knee flexion if tolerated, and patellar mobilization. The criteria to progress to the next stage are minimal swelling, pain free range of motion between 0 to 90 degrees, good quadriceps activation, and walking with brace support. Pertinent to note here is for meniscectomy, weight bearing is tolerated earlier than meniscal repair, and hence in meniscectomy we see a faster progression in weight bearing. Weight bearing is gradually progressed in this phase, and by 10 to 12 weeks, most patients achieve full weight bearing. Range of motion of the knee is also restored gradually to its complete range. The strengthening of the muscle progresses to closed chain drills, which are more functional and provide stability to the knee joint. Balance and proprioceptive training, like the single leg stance, are introduced, ensuring controlled movement patterns without stressing the repair. The key intervention in this phase are close kinetic chain strengthening exercises like step ups, mini squats, balance and proprioceptive drills, and using stationary bike or the elliptical machine for maintaining the aerobic fitness. The criteria to progress to the next stage are restoration of full knee range of motion, strength of more than 75% as compared to the uninjured limb, no joint line pain or swelling is to be experienced or seen after exercise, and functional balance is to be achieved by the patient. In the final phase of rehab, strength and endurance training are intensified. Low level agility and controlled plyometry exercises are introduced as tolerated by the patient. Sport specific drills are initiated later in this phase with careful monitoring for pain or swelling. Return to sport is usually targeted between 4 to 8 months, depending on the type of tear and healing response. The key interventions in this phase are plyometric and agility training, the ability to perform cutting and pivoting tasks, sport specific drills close to 7th or 8th month of rehab, and neuromuscular training program. Criteria to progress to the next stage are restoration of full and pain-free range of motion in weight bearing, as well as weighted squats like goblet squats, strength of more than 90% as compared to uninjured limb, the ability to perform sport specific drill with good quality of movement and without showing any hesitation during any movement. Pertinent to note here is for meniscectomy, the return to sport can be anywhere between 6 to 12 weeks once the criteria for return to play are met. In contrast to repair, partial meniscectomy rehab is much faster. Patients typically bear weight as tolerated within a week. Passive, non weight bearing range of motion is usually restored in 2 to 3 weeks. Strengthening, balance, and functional exercises begin early in partial meniscectomy cases, with return to sport commonly achieved between 6 to 12 weeks. However, long term joint protection is compromised compared to repair. Chances of secondary injury in these cases increases. Patients after repair must demonstrate more than 90% strength symmetry in this case. To pass the criteria to return to sport, a patient must be able to clear the hop and agility test without any discomfort. These tests can be repeated by the investigator to see the repeated performance of the individual. The patient should not report of any instability or pain while performing these functional tests. For meniscectomy, the clearance is faster, but still it requires pain-free range of motion and restored strength. In all cases, psychological readiness and clearance from both the surgeon and physician are essential. The criteria for clearance is strength of more than 90 to 95% of the uninjured limb, clearing the Hop battery of tests with more than 90% as compared to the uninjured limb, no joint line tenderness or effusion after performing the activity, and passing the sport specific functional drills. Meniscus is a critical shock absorber and stabilizer of the knee joint. A meniscal repair is preferred over meniscectomy for long term joint health of the knee. Rehab after repair is slower but is protective in nature. And while meniscectomy allows faster return to sport, it also causes higher incidences of osteoarthritis and total knee replacement. These are some of the references that I have used in my study. With this, we have come to an end of meniscus rehabilitation. We have now completed ACL, MCL, LCL, PCL, PLC, and meniscus rehabilitation protocols. In the next chapter, we will look at multi-ligament knee injury and how and what considerations are to be taken during such injury rehabilitation.